So you're recognized, Doctor. Good to see you.
Thank you for yielding, Madam Chair. And Ranking Member Guthrie, thank you for all the witnesses for being here with us today to discuss this incredibly important issue. I want to first talk about a case that I personally was involved with. 10 years ago, I diagnosed Charlie, a 62-year-old man with melanoma on his right thigh. And at diagnosis, the disease was only found locally, and further evaluation showed that there at that time was no spread of the disease. 2 years later, he developed evidence of metastatic melanoma involving internal organs. And then he received what was at that time standard of care therapy with interferon. And unfortunately, his melanoma progressed. Subsequently, he was started on one of the new immunotherapies that have been approved for metastatic melanoma, similar to what we know President Carter has subsequently received as well. Initially, his disease did respond to the therapy, but within weeks, the melanoma continued to spread. My then 64-year-old patient was started on a different immunotherapy to treat his melanoma. His response was remarkable and it was significant. He continued on that therapy until complete remission of the disease was attained. Today, 10 years later, he is symptom-free, he is disease-free. His imaging studies, which include CAT scans, MRIs, PET scans, show no evidence of disease. Last Friday, April 30th, I talked to Charlie on the phone, and he has such great insight on how the opportunity to have tried 2 different immunotherapies as a treatment for metastatic melanoma have allowed him to be completely cured. During that phone call, I asked Charlie, if he had been given the opportunity to have tried a second immunotherapy, but not have had that here in the United States, he said I would have pursued it wherever I could. But given the opportunity to have tried a second immunotherapy after the first one failed, I asked Charlie, what does that mean to you? Charlie's very blunt and straightforward with me. He said, without the opportunity to have tried 2 immunotherapies to treat my metastatic melanoma, I would be dead. The drugs that he was allowed to use were Opdivo and Keytruda, and they presented huge advancements in the treatment of metastatic melanoma. The chance to have 2 therapies for metastatic melanoma has allowed today for patients to be cured. My questions first are for Dr. Gupta. Knowing that there are countless tragic stories of physicians in other countries who cannot allow their patients to have these innovations because they don't have access to it because of their government authority. Opdivo is only approved for 5 of the 14 indications in Australia. And in France, only 4 of the 14 indications are approved. This frustration should serve as a warning to all of us, to American patients, to American physicians, that if we go down the path of HR3, we're going to lose access, innovation, and cure. Dr. Gupta, as a physician, can you tell us more about what HR3's foreign price controls would mean for U.S. physicians and for the patients that you serve and the patients that need these innovations?
Well, thank you, Congressman, for the opportunity. And I think it's absolutely right that other countries have shown a willingness to block groundbreaking medicines from reaching their citizens. And I think that's morally indefensible. I think that's the last thing that we should be trying to import from another country. As a physician, having had the privilege of practicing medicine like yourself, what I most wanted for my patients was for them to get the medications that were prescribed to them. And there should be nobody coming between a patient and their doctor. And I think that we should not be emulating the systems that other countries have to blockade innovations from getting to patients.
So is it fair, Dr. Gupta, to say that American doctors could be put in that position where they wouldn't be able to prescribe what they know their patients need and what they know could cure their patients?
I think that's possible, yes.
And does that mean that these patients, particularly our most vulnerable, may be at risk for worse health complications, worse outcomes, if restricted access to drugs and therapies were implemented?
Absolutely. As we've heard, not just days, but hours and minutes can matter. And it's a matter of getting innovative drugs to patients as fast as possible to help the most number of people. And I think that's what we all are attempting to do.
I thank you for your answers. Madam Chair, I thank you for allowing us to present and talk about access, innovation, and cure. And I yield my remaining time.